All fixed. A very good morning. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today, we have a presentation on bacteriuria in pregnancy and elderly, and also catheter-associated UTI. So this will be presented by our resident, Dr. Devashish, and moderated by our faculty, Dr. Sumit. So I request all of you to kindly, Dr. Devashish to kindly share his presentation and go ahead, please.
Hello. Hello. Good morning, respected sirs and my colleagues. Today's topic is, as I told, bacteriuria in pregnancy, the first topic. Now, it is prevalent in 2 to 7% of the pregnant women, and the risk factors in pregnancy leading to bacteriuria are multiparity, sickle cell trait, and low socioeconomic status. During pregnancy, the conversion of asymptomatic bacteriuria to pyelonephritis increases from 1 to 2% in general population to 15 to 45%. And this leads to prematurity and low birth weight and increased prenatal mortality. Now, coming to the consensus guidelines, it mandates the early screening of for asymptomatic bacteriuria during the 12 to 16 weeks of pregnancy. It is backed by the United States Preventive Safety Task Force and the American College of Obstetrics and Gynecology and Infectious Disease Services of America. Now, coming to the pathogenesis of increased bacteriuria in pregnancy. Now, the anatomical reason. Under the hormonal influence, the progesterone, it induces the smooth muscle atony, decreasing the ureteral peristalsis, and estrogen drives the bladder hypertrophy. There is also expanding uterus compressing the ureters, resulting in bilateral hydroureteronephrosis, and bladder displacement occurs, which is pushed upwards and anteriorly with hyperemia, congestion, and increased capacity. The physiological changes that leads to increased infection are raised GFR to the tune of 30 to 50%, renal plasma flow, renal length increased approximately about 1 centimeter. There is decrease in serum creatinine, serum urea, and there is associated proteinuria during pregnancy. Both these factors, anatomical and physiological, leads to hydronephrosis and increased chances of ascending infection and risk of pyelonephritis. Now, coming to the diagnostic screening criteria. Now, all pregnant women during their pregnancy, 12 to 16 weeks, have to undergo a urine culture, which is the gold standard. If it is negative, early culture, then there is low probability of developing bacteriuria. And if it is a positive culture, then we should treat these patients. And urine analysis does not play a role in screening. And also you have to take history for high-risk patients, like patients who have history of recurrent UTI and vesicoureteric reflux. They need to be treated even earlier than 12 weeks. Now, during pregnancy, there is altered pharmacokinetics. There is drug clearance and distributions are altered due to increased GFR and increased volume of distribution, and therefore the dosing requires adjustment. And the pathogen profile, however, remains the same and usually enterobacteriaceae. Coming to the drugs that are safe during pregnancy, the safest drug is the aminopenicillins and cephalosporins. And there are drugs which have to be used with some caution, like nitrofurantoin. They are safe in second and third trimesters, and it should be avoided near term due to its there is a potential risk for G6PD hemolytic anemia in the fetus. As per the SCOG guideline, use in first trimester only if no alternative exists. Sulfonamides are generally safe in second and third trimester. Contraindicated drugs are the fluoroquinolones because they cause cartilage damage. Tetracyclines, they can lead to fetal malformations. Chloramphenicol, they lead to gray baby syndrome, and trimethoprim, they can cause folate inhibition, leading to neural tube defects. Now, coming to the management protocol of asymptomatic bacteriuria, the first step is to identify the causative organism via urine culture. The second step is to give appropriate antibiotic agent, usually a cephalosporin. And the third step is the duration of therapy should be kept for 4 to 7 days. And this duration significantly cures the asymptomatic bacteriuria. And as per the Cochrane trial, the data suggests that the targeted antibiotic therapy drastically reduces the incidence of pyelonephritis, preterm delivery, and low birth weight in children. The post-treatment follow-up, we have to always repeat our urine culture. It is mandatory, and the bacteriuria is identified. If it is identified, then we have to give structural therapy. Suppressive therapy is indicated if there is one episode of pyelonephritis or 2 episodes of cystitis. The suppressive agents used usually are nitrofurantoin and cephalexin. If there is risk pyelonephritis set in, that is, it is a severe systemic infection causing major contributor of maternal morbidity and 10 to 20% recurrence of death. Then we have to immediately stop the oral therapy and switch on for aggressive inpatient care. We have to admit the patients, start IV antibiotics. Usually preferred antibiotics are beta-lactams, and the carbapenems, however, are reserved for severe or multi-drug resistant cases. The monitoring is done for 48 to 72 hours. If it isn't resolved by 72 hours, then we have to get a renal ultrasound immediately to rule out other causes like renal or ureteral stones, mechanical obstruction, and renal abscess. Now, here are the NHS guidelines. We have to screen all pregnant women. Dipstick is not reliable for this. And asymptomatic bacteria is defined by NHS as more than 10 to the power 5 colony forming units per ml without any symptoms. And we have to confirm with 2 cultures. Symptomatic UTI, like dysuria frequency urgency is there. Why it is important? Because 30% conversion of pyelonephritis, and this have prompt preterm labor and maternal morbidity. And treatment should be given for 7 days. The first line is nitrofurantoin, alternatives are cephalexin and amoxicillin. Follow-up test, we should always get an culture done. And the special points are the GBS bacteria interpreter antibiotic prophylaxis persistent. There is a recurrence and close surveillance. The important thing is to remember is E. coli is very common and urine culture is the gold standard. And untreated ASB has a high risk condition. Now the EUA and AUA recommendation also back the similar findings. Screening and treatment is done, and rationale is to prevent the pyelonephritis. The antibiotics use a similar same evidence for cephalosporins and nitrofurantoin, and we should avoid fluoroquinolones and tetracyclines, and duration is 3 to 7 days, and follow-up culture is recommended. Now coming to our next topic, management of bacteriuria in elderly. As we know, there is a demographic shift due to increasing life expectancy due to better medical facilities, and the clinical impact is that the UTI is a major public health issue in this age group of populations. And the critical focus area is the geriatric care providers and urologists to take care of this problem. The prevalence is, it is more common in females to the tune of 20% in general population and 25 to 50% in old age home cares. And in males, it is 6 to 15%. And in old age home cares, it is to the tune of 15 to 40%. Now, the pathogenesis is multifactorial. First and most importantly is the immunological decline with age. The second important factors are incomplete bladder emptying or neurogenic bladder dysfunctions, incontinence leading to direct perineal contamination, increased utilization of catheterization due to age-related issues, and estrogen deficiency in females, which leads to altering local flora and increased incidence of UTIs. Now, in diagnostic challenge, deep stick testing cannot be used because of poor sensitivity and specificity. It is better utilized to rule out any infection rather than confirming the infection. Only pyuria is not a criteria for screening or treatment because it is exceedingly common in elderly population. It is not diagnostic. Again, delirium is a symptom of UTI, but delirium itself does not mandate that the patient has UTI. Whenever a patient comes with altered mental status, we have to hydrate the patient first, then we have to observe the patient. If the symptoms resolve, then we do not need to do a urine test. However, if the symptoms persist, then we have to confirm the UTI with a culture. So for asymptomatic bacteriuria in elderly population, do not screen, do not treat motto is followed. Its application is explicit for both general population and the home care population, and its rationale is no linked benefit for treating asymptomatic UTI and preventing renal deterioration and improving incontinence. However, it can increase the drug toxicity and antimicrobial resistance. Now, to diagnose the case in elderly, we have to follow the McGeer criteria. Its diagnosis in standard general population is more than 10 to the power 5 colony forming unit per ml, and in catheterized patient, it is more than 2 CFUs per ml. In non-catheterized patient, usual symptoms are dysuria, fever, LUTs, and costovertebral angle pain, hematuria, and increased urgency or frequency. And in catheterized patient, symptoms are fever, hypotension, suprapubic pain, and mental status change and leukocytosis. The most common organism is E. coli, 50 to 75%, and it is the dominant pathogen. However, the flora is expanding due to with Proteus, Klebsiella, Pseudomonas, and Enterococci. And complex polymicrobial cases are also being commonly found now. Now there is a vicious cycle. Now the more and more patients, elderly patients, are institutionalized, and the use of catheter incidence is increasing, leading to repeated and empiric antibiotic administration, leading to more resistant polymicrobial flora emerging. Therefore, the indications for evaluation and escalations are as follows. High-risk situations like structural abnormalities, severe diabetes, presence of urea-spitting organisms, and increased sepsis risk with catheters, immunosuppression, and prosthetic devices. We should evaluate for renal dysfunction, stone, hydronephrosis, urinary retention, and neurogenic bladder. And required investigations are the serum creatinine, USG, imaging like ultrasonography, CT scan, urodynamic studies, and cystoscopy. And complications in elderly populations can be renal failure, infection, stones, and sepsis. So what drugs to use? There is a very narrow therapeutic window in elderly because of physiological concerns. There is decreased renal clearance, which leads to dangerous drug accumulation, elevated risk of adverse effects, and complex drug interaction and renal toxicity. So for treatment, we treat only the clear symptoms are present and prefer culture-guided therapy over guessing. And the goal are to symptomatic relief and not urine sterilization. The duration is usually for 3 to 6 days effective, and in severe UTI, you will use for 10 to 14 days. We should avoid fluoroquinolones in old age because it has increased risk of tendon rupture, and CNS side effects can be there for like delirium. So it should not be used as a first-line empiric therapy. The EUA and AUA recommendations are also in the similar lines. They don't recommend screening or treatment in elderly population. The rationale is no benefit in mortality or renal function. Symptomatic UTI only you have to treat. Delirium alone does not, and pyuria does not qualify for treatment. And we have to treat only where there is clear LUT symptoms and signs and proven culture is there. Now coming to our third topic, catheter-associated urinary tract infections. It is the most common hospitally acquired infection. The incidence increases with 10% per day of catheterization. The clinical progression is 10 to 30% of bacteria cases become symptomatic, and it has a huge economic burden. Now, definition of catheter-associated urinary tract infection is indwelling catheters for more than 2 days, urine culture showing a single organism of 10 to the power 5 CFU per ml, and with clinical symptoms like suprapubic tenderness, costovertebral angle tenderness, and frequency urgency dysuria, fever more than 30 degrees Celsius. Remember, bacteriuria is not equal to catheter-associated UTI. Asymptomatic bacteriuria is bound to develop when the patient is catheterized. But for COTI, we have to have all the three. Now, the indicators for laboratory investigations are clinical presentation. Most patients of bacteria are asymptomatic. If there is the symptoms that we have discussed, then we have to go for laboratory test, and 10 to the power 5 CFUs must be identified. Pyuria is almost universally present and it is not diagnostic. And urine dipstick test is also not validated for diagnosis of COTI. Now, the primary routes for catheter-associated UTI contraction are, first one is the mechanical inoculation at the time of insertion due to poor technique or breach of asepsis. The second route is via the ascending outside the catheter along the urethral mucosa, exceptionally high in female population due to strictly preceded by mucosal colonization. The third route is the ascending inside the catheter lumen. Now, the most common mechanism that is a challenge in catheter-associated UTI is the biofilm formation. It is the matrix formation begins within minutes of insertion of the catheter. Then the second stage is the planktonic stage where the free-floating urinary bacteria are seen. Then the sessile phase where the catheter surface is adhered with bacteria forming the biofilm core. It forms an antibiotic-resistant extracellular matrix and blocks the drug penetration. There is encrustation of mineralization of the matrix physically obstructing the catheter, and the sessile layer acts as an invincible bacterial reservoir. And the most common organisms identified in these biofilms are Pseudomonas and Proteus species. In short-term catheterization, the dominant pathogen is, however, E. coli. And there can be secondary invaders of Pseudomonas, Proteus, and Enterococcus. In long-term catheterization, there is a polymicrobial shift. The environment transitions into a highly complex multi-species colonization. The complexity is frequently involves 4 to 5 different organisms coexisting and sharing resistant plasmids within the biofilm matrix. Now, coming to prevention of catheter-associated urinary tract infections. The appropriate indications is strict urinary output monitoring, prolonged, and so first of all, where to put in a catheter? It should be reserved only in ICU settings, surgical procedures requiring prolonged surgical procedures, and for specific urologic surgeries where you need some structural healing of anastomosis. Now, material efficiency we'll discuss later. So as we know, prevention is better than cure, and we also focus on early removal of these catheters if you plan to put in these catheters. Now, there is 6C bundle daily working guidelines to reduce the incidence of catheter-associated urinary tract infections. First C is the consider. Consider to assess the daily necessity for the catheter, whether we need to put it or not. Second is connect. Maintain a continuous closed drainage system. There should be minimal breach in the system. Clean. Daily metal care using water only. We should avoid antimicrobial cleaning because it increases and the resistance. Closed system. Aseptic insertion and never breaking the anesthesia. Culture. Only send samples. Call irrigate only when clinically indicated. That is clots or obstruction, not for pyuria. So if you follow these 6C bundles, it has shown 70% reduction in catheter-associated urinary tract infections. Now, clinical management, we have to assess and treat only the patients who are definitely symptomatic. We have to send a culture before starting any kind of empiric antibiotic therapy. Source control should be done. That is, you have to change the catheter whenever you suspect a COTI. And the duration of antibiotics, you should stop the antibiotics whenever there is symptomatic relief within 48 hours of symptomatic relief. What not to do? No prophylactic antibiotics because benefits are only temporary. and no antimicrobial metal cleaning because it alters the flora and increases the resistant bacteria. The special population that are prone for getting COTI are the spinal cord injury SCI patients. These patients have exceptionally high bacteriuria rates, and most common cause of fever in these patients are UTIs. What are the pathophysiology behind that increases the risk? That there is poor bladder emptying, causing chronic stasis and creates ideal bacterial reservoir. High pressure dynamics compromising the mucosal immunity and barrier function. Bladder stones incidence is more in these patients, and they act as a nidus for persistent infection. And there is increased chance of UR, and which provides a highway for ascending pyelonephritis. So the other risk factors of catheterization in these SCI patients are: if you put an indwelling catheter, it has the highest risk and major source of infection. Suprapubic catheter also similar risk factor, very high risk, and long-term profile are same. If you use a condom catheter, it also has slightly less chance, but still high risk to contract UTI. However, the clean intermittent catheterization has the lowest risk and is the gold standard in management of neurogenic patients of SCI, spinal cord injury patients. Advantage of CICs are: it has superior infection control as it dramatically reduces the urinary tract infection rates. Bacteriuria incidence is only to the tune of 1 to 3%. And per catheterization. Structural prevention, it decreases the chances of bladder stone formation because of complete and regular evacuation, and long-term outcomes are chronic urological complication compared continuous indwelling catheter are much better. Now, we'll discuss the various types of catheter options that we have. The first is the standard catheters versus the silicone catheters. No significant difference in COTI incidence. So, but in silicone, there is better long-term use, less encrustations and allergy-free, but COTI advantage is not there. Second is the silver-coated catheters. These are usually coated with silver oxides or alloy. Benefit is shown in short-term catheterization, but however, no benefit in long-term use. Coming to the third group, nitrofuranzane impregnated catheters, slight reduction in COTI and problem increased discomfort, cost, and not routinely recommended. Hydrophilic catheters are usually the catheters that we use in the CIC. However, if kept for long term, again they are similar profile for COTI. Suprapubic catheterization, as discussed, has similar long-term infection rates. However, advantage is delayed onset of bacteriuria and better comfort and hygiene. Other experimental approaches are bacterial interference, non-pathogenic colonization, anti-biofilm coatings over the catheter, antibiotic coated catheters. Still, these are not standard practice. Now, coming to the recent evidence regarding the COTI, so this is a nice paper, Catheter-Associated Infections, Current Challenges and Future Prospects. And it has got a high baseline, there is a diagnostic challenge, difficult to differentiate between asymptomatic bacteriuria versus COTI. Urinary culture cannot distinguish the colonization from infection. Pyuria not reliable in catheterized patients. Symptoms often are subtle and missed. The other problem that we have is the problem of biofilm, as discussed earlier, and major reason of treatment failure. There is a microbiological shift. MDR organisms are found, polymicrobial organisms are found, E. coli still is common, but again, the incidence of Pseudomonas, Proteus, and Enterococcus species are including. We have to take antibiotic stewardship. Major issue is over-treatment of asymptomatic bacteriuria. This leads to resistance and adverse drug reactions. So the current focus is only to treat the symptomatic COTI. The prevention is the key. Focus has shifted from treatment to prevention. Strategies are avoid unnecessary catheterization, early removal, and close drainage. So the take-home message is the biggest challenge in catheter-associated UTI is not infection, but distinguishing the infection from colonization. Again, the UA and AUA recommendations are on the similar lines. There is no role of screening and treatment of asymptomatic COTI, and diagnosis is symptoms plus a positive culture required. And key symptoms are severe flank pain, suprapubic pain. Management is culture, antibiotics, and catheter change. Catheter management is remove early, avoid unnecessary catheterization. Prophylactic antibiotics not recommended. Prevention is aseptic insertion and closed system. And however, bacteriuria is inevitable. So the final take-home message is in pregnancy, if there is asymptomatic bacteriuria, screen and treat because it has got a high incidence for conversion of pyelonephritis to the tune of 40%. So always treat ASP. The drugs used are penicillin, cephalosporins, and nitrofurantoin, and it prevents the pyelonephritis and preterm birth. In elderly and COTY population, no role of regular screening and treatment of asymptomatic bacteriuria. In elderly, only treat the symptomatic UTI, and in COTY, when there is symptomatic and culture proven, treat the patient. In elderly, avoid over-treatment. In COTY, change a catheter, use antibiotics, stop the antibiotic when symptoms are relieved within 48 hours. In COTY, the most challenging thing is the biofilm resistance, and in elderly, the asymptomatic and colonization differentiation is a challenge. Thank you.
Thank you, Devashish. So again, any comment, query from residents or faculty or those who might have joined us today, most welcome. So in today's era, this whole presentation is very, very significant because antimicrobial resistance is increasing every day, and soon we will have very few antibiotics to treat infections. So even mild to moderate infections may be fatal in the near future. So we should try to protect antibiotics. So that's why it's very important that we do not use antibiotics in asymptomatic bacteriuria. So conditions where it is indicated, as I said, in pregnancy, we should treat asymptomatic bacteriuria. In patients who are transplanted within 3 months, first 3 months, if they have asymptomatic bacteriuria, it should be treated post-transplant. And the third most important is the urological procedures if we are doing, and if we want to make a mucosal incision during the procedure, we should always treat these patients before we take up for those urological procedures. These are all in literature. So only one thing that I feel that should be added is many patients who want to get implants, like knee implants, etc., or cataract surgery. Usually it is said that even if the urine culture is positive before the surgery, you should treat them. So this, I think, indication may be added. So the first topic, asymptomatic bacteriuria, we all know in pregnancy, it's very important to screen the pregnant women as early as possible, first term only. And if, as he said, there are 2 to 7% of females who may have asymptomatic bacteriuria without any symptoms, and they should be treated because 30 to 40% may have future urinary tract infection, and some of them may have pyelonephritis. And it also affects the baby in the form of low birth weight and preterm deliveries. So it should always be treated, and there should be a test of cure after every treatment. So after 6 to 7 days of treatment, completing the treatment, you again repeat the urine culture and see whether the culture is negative. And in females, always have 2 samples, right? So 2 urine cultures should be positive to treat asymptomatic bacteriuria. And it's also indicated that every term when the patient is coming to the physician or gynecologist, they should have a test for urine culture. So at least every 3 urine cultures, even if they do not have asymptomatic bacteriuria. Antibiotics, as I said, nitrofurantoin, fosfomycin, and cephalosporin. These are the best. Nitrofurantoin may be avoided in the first term and last few days of the term. And cephalexin can be given and fosfomycin can be given. When we talk about bacteriuria in elderly, so bacteriuria is not just presence of bacteria in urine, mind it, is culture positive. When you have a midstream urine culture which has 10 to the power 5 colony forming units, and if you are taking a catheterized sample, even 10 to the power 2 is good enough to call it as bacteriuria, right? So it should be always noted that it is culture positive, that is bacteriuria. So even culture positive asymptomatic bacteriuria should not be treated in majority, right? So elderly, as I said, it's very common, both males and females, both community and those who are in nursing homes for long-term care. There it is even more common. And almost more than 50% of elderly men or women above 75, 80 years will have asymptomatic bacteriuria. And this need not be treated, only in very, very specific cases, or those who are symptomatic definitely should be treated. The third was the catheter-associated UTI. So catheter-associated UTI, in the last slide, you said symptomatic, asymptomatic. There's nothing like asymptomatic COTI. COTI is always symptomatic. So that by definition, COTI is defined as UTI, symptomatic urinary tract infection. If it is not symptomatic, it is not COTI by definition. So even if the patient who is catheterized and you have bacteriuria, where is the culture is positive, the patient doesn't have symptoms, should not be treated. All right? So every day of catheterization increases the chance of UTI by 3 to 7%. So we have to reduce the catheterization duration as much as possible. So as I said, prevention is the most important thing. And only those patients who require catheterization should be catheterized. Not every patient with a small caliber catheter. And then the preventive measures those are important. That is the closed system. It's very important that many times when you think the catheter is not going properly, or it's just behind the thigh, or you'll just open it and then again join it. That's a very, very wrong trend. You should never open the system. Only in cases when very important, when you have to wash the clots, etc. And that too has to be done in very aseptic manner. So never open the closed system, all right? And secondly, the urine bag should always be below the bladder. It's very important. If it remains above the bladder, then there is always a more chance of infection. So always keep the urine bag below the bladder. And then cleaning of the meatus, only with water, no antibacterial solution. And another thing that we can add is to prevent is, before catheterization, we can just give an intraurethral antiseptic solution like betadine, or sometimes intraurethral gentamicin, etc., to prevent the infection, chance of infection. We know the catheter is very important, that we remove the catheter as soon as possible when it is not required. Secondly, there are fenestrated catheters also. When we tried a study about, I think, 25 years back, making the Foley's catheter fenestrated. Why? Why fenestrations help in preventing infection? So this catheter, which is almost snugly with the urethral lumen, will kind of prevent the secretions of the urethral glands coming out, right? So those cause urethral gland infection, and that infection can ascend up into the bladder, causing UTI. So if you allow these secretions to come out through the catheter with those fenestrations, it also reduces infection. So these are few things that I think we should also look into to how to reduce the infection. I think that was in brief about all these three topics related to asymptomatic and symptomatic bacteriuria in pregnancy, elderly, and catheter-associated UTI. A very important topic. You can get a kind of a question in the theory also, and definitely practically. In practical, you may be asked, right? So any comments? Any queries from the, otherwise we'll take up the MCQs. Dr. Samindra, you want to look? Okay. So let's go ahead with the MCQs. So nobody has any problem, Rajat? बोलो.
Patient of PFUI, we are placed in SPC, and he has to undergo orthopedic surgery, some implant. But they are telling that you first get urethroplasty done, then we'll treat. So what should be the
Please try again. I change settings.
So we have tried to implement a new way of taking the MCQs, a more kind of innovative and interesting way.
Sorry, one user is connected.
Okay. Is it there? So in pregnancy, asymptomatic bacteria is defined as A, B, C, D. So B. Okay. Let's see.
A new pin is 343943. 343943.
So should I?
Connected? Yes, I can see.
All right.
Two players have joined. 3, 4, 6, 7, 8, 9, 10.
So this is being
Let's start.
played by all residents on their mobiles also, so that we will be able to know how many have given the correct answers. So the second question is screening method of choice in pregnancy. Dipstick, microscopy, urine culture, CT scan. Screening method of choice. Yes. All right. So should we I have to
First
click?
question.
First question again?
First question is playing now. Second.
Okay. इसमें नहीं साथ में आ रहा है क्या?
Now.
Okay, the screening method of choice in pregnancy. Dipstick, microscopy, urine culture, CT scan. So it's all very easy. Should I click here?
Sir, 5 seconds.
Okay. So we all know the answer is urine culture is the gold standard. So how do we know how many have?
Here,
there only, here only you can't see. Okay. So untreated asymptomatic bacteria in pregnancy leads to renal failure, pyelonephritis, bladder cancer, AKI. So again, very easy, pyelonephritis, 30 to 40%. And there could be preterm babies and low birth weight babies. So leave it. First line drug in pregnancy. Cipro, nitrofurantoin, tetracycline, gentamicin. So we all know nitrofurantoin. Tetracycline causes fetal malformation. And gray babies by chlorphenicol. Yes. And trimethoprim causes folate inhibition. Right? And fluoroquinolones, cartilage injuries. And baby may have also cartilage issues. All right. So asymptomatic bacteria in elderly, always treat, never screen or treat, treat if pyuria, treat if culture positive. Asymptomatic bacteria. Never screen or treat. That's the answer. It should not be treated. Even if the pyurias, they're not treated. Even if the culture is positive, not treated. Right? Delirium alone in elderly suggests UTI, asymptomatic bacteria, not sufficient for UTI, pyelonephritis. Not sufficient. So though in the first, one of the important symptoms in elderly after a symptomatic UTI is change in the mental status. So delirium could be a part of the symptom, but only delirium will not say that this is UTI, all right? COTI diagnosis requires pyuria only, culture only, symptoms plus culture, fever only. All right, so COTI diagnosis, symptoms plus culture. So it's not just culture. So if there is bacteriuria, asymptomatic bacteria doesn't come under COTI. So it's a symptomatic bacteriuria, right? Biofilm formation after 1 week, within minutes, after 24 hours, never forms. Huh?
Within minutes.
Within minutes. So biofilm gets formed within minutes. Okay. Best COTY prevention: antibiotics, catheter removal, silver catheter, nitrofurazole. COTY prevention, catheter removal, I think. So if the catheter is no longer required, definitely remove the catheter. Even if there is catheter-associated infection, then also changing the catheter will help, right? Silver catheters benefit: long-term COTY prevention, short-term bacteriuria reduction, no role, cure infection. So only for short-term reducing the bacteriuria. It doesn't help in long-term. Pyuria in catheterized patient means definite infection, colonization, not diagnostic, needs antibiotics. Not diagnostic. Pyuria can be due to many reasons. If a foreign body in the urethra can produce pus cells, right? Not necessarily there is infection, whether symptomatic or asymptomatic. Identify the person. Who is he?
Sir, clue he invented CIC.
Oh, CIC. Who invented CIC? Come on, don't tell me that you don't know. Huh? Gone. Nobody.
Dr. Jack Lapidus.
Lapidus. Lapidus CIC is very, very, I think, I don't know how you missed that. So, introduced CIC, shifted concept from sterile to clean technique. Associated contributors were Silber, Diokno, and William Lowe, right?
Yes.
Okay. Silber is also known for his technique of vasoepidermal anastomosis, right? Silber. Right. So thank you.
Result is there.
So the result is, what is the result?
Bouncy hit.
Bouncy hit is top with 8%.
Bouncy hit. Who is bouncy hit? Who was bouncy hit? Huh? और कोई था? Second is Frank data.
Freak data.
Freak data. ये सब है ही नहीं कर. Huh?
बीच में stop.
Captain Hacker. So these are the people who, and the zero include a random.
So actually, probably it has stopped. That's why.
That is why it is. So Dr. Police is the last one. Who is Dr. Police? Chalo, anyway. So interesting way to finish the topic. Thank you. If anybody doesn't have any comment or query, I wish all the best. Have a good day. Thank you.